Well, thank you very much. I was hoping he wouldn't raise expectations too high. I guess that's a bit too late for that now. I'm very pleased to be here. I would like to acknowledge the previous speakers, and particularly the Honorable David Clark. Very honored to have you attend this lecture today, and all the best to you and your government as you pursue narrowing the gap for mainstream New Zealanders, but also Indigenous Maori in the area of diabetes and other chronic conditions. And also to acknowledge Mark Brunton for your kind words as you sort of opened this meeting in a good way. It's really important that we acknowledge the territory, and I'll do that in a second. For myself, I'm actually a First Nations person from Canada. I am a member of the Tyendinaga First Nation on the North Shore of Lake Ontario, and it is actually some Mohawks are in Canada and some are in the United States, and the reason is some sided with the British and some sided with the Americans during the American Revolution and the War of 1812. So I guess my ancestors sided with the British. In fact, one of them was a captain in the British Army. So that's the reason why we're in Canada. I think I need to turn this. There are a number of organizations that I kind of work with and represent. This first one here with the heart and the slash, that's supposed to be heart and stroke. So, top marks if you figured that one out. Providence Healthcare is sort of like a health management organization. It includes hospitals and other healthcare facilities. I'll talk a bit about that. And of course, the First Nations Health Authority, which is the first time a First Nations group, the entire province of BC, British Columbia, has gotten together to organize health services. There we go. So the first thing I wanted to do was acknowledge the Tangata Whahana. I respectfully acknowledge the people of Kai Tahu, on whose land we are meeting today. I hope I got that right. Pretty good for a Canadian. So I'm really pleased to be here. I just love this country, and I think we have a lot in common. And this time of year, that's a nice latte in Canada. It's a little bit icy and cold, so it's a pleasure to be here during the Canadian winter. Tim Hortons is a coffee shop that understandably was started by a hockey player, as you can imagine. So who are Indigenous peoples of Canada? Well, it turns out that in the Constitution of our country, we recognize 3 Aboriginal or Indigenous groups. First Nations, Inuit, and Métis. And the term Aboriginal is also recognized in the Constitution, recognized as having special rights. The trick is no one knows what those rights are because they're not articulated in the Constitution, but we have special rights. They get defined all the time. These are just some standard slides that are very similar, so I'll go through them very quickly, but you can see the population pyramid showing that 46% of the Indigenous people are under the age of 25 and 29% for the rest of the Canadian population. So a young and growing population with over 50% as First Nations. The other 2 groups are First Nations and Inuit. And of course, this is Canada, the geographic territory, and it's basically showing the blue bars are the proportion of non-Indigenous people in those regions, and the red bar, the red circles, parts of the pie, are the Indigenous people. So you can see that in the north and in the Midwest there's larger numbers, relative numbers of Indigenous people, but the absolute numbers are greater in the higher population areas like Ontario in the center of the... So it's basically there's a north and a west kind of distribution where higher proportions of Indigenous peoples live. This is me in my previous life. I just wanted to put this up to come clean that I actually did do clinical research at the University of Toronto Department of Nuclear Cardiology before I decided to go into Aboriginal health. And it was really my first love doing that kind of research. And right now, my research program is based at St. Paul's Hospital in the cardiology department, connected to these other organizations. That hospital was built in the 1930s, and if there's a large earthquake in Vancouver, apparently only 10% of that building will be standing. So consequently, the asset of a hospital and everything it contains will turn into a liability. So obviously we need to build a new hospital, and that's the plan for the new construction. The reason I put it up there is because there's opportunities to engage Indigenous people's health and well-being in a healthcare institution that's being built and will probably be standing for the next 100 years. So that's a big part of my interest, is looking at the intersection of health services at a hospital, St. Paul's. That's kind of a faith-based hospital, as you can imagine. First Nations Health Authority, which delivers services and creates policies, and then the university where advanced knowledge is created. And so it's about thinking about these terms. It's treatment, discovery, and advocacy, but it's in those spaces between those things and the intersection of those areas where exciting things can happen. You can create new research knowledge, you can advocate for different kinds of programs and services, and then you can lead to treatments. So the intersection, it's about having the people who produce knowledge connected to the people who consume that knowledge to improve the health of people. That's a different way of organizing health research and policy. This is the Canadian Institutes for Health Research, which used to be the Medical Research Council of Canada. I'm taking you back to 2000 when it was first created. There are 13 scientific directors there. Alan Bernstein is seated in the bottom. And this organization has annual funding of about $1 billion, which pales in comparison to the NIH, but is pretty significant in Canadian terms. So of these 13 institutes, there's a woman there, Diane Finegood. Many of you may know, sitting next to Alan with the mustache. She was the Institute Director for Nutrition, Metabolism, and Diabetes. And as you can imagine, we had a lot of interest. I'm in the back row standing up. We did a lot of collaborating, and among these institute directors, we collaborated on all kinds of projects around cancer, heart disease, public health, health services research, and those collaborations were a game changer. It was an opportunity to sit at the table where priorities for advanced knowledge creation could be determined and funded, and we actually created capacity in these areas across it. It was a very, very exciting time to be involved with that. So one of the things I wanted to talk to my colleagues who were in biomedical clinical research was this notion that diseases have two causes, and it's been known for a long time, more than 100 years. The first, of course, is pathophysiological, and the second is political. And so I want to talk to a little bit about that in the context of Canada, and this is just one case study of many. It has to start off with a conversation around colonization and the expansion of European power. And I think a lot of us understand this. And you can see that this is from the 1700s, and there had been some migration towards the Americas, primarily for the purposes of trade. Again, you can see coming up a couple of hundred years into the 19th century, you can see that the colonial expansion from Europe had extended pretty much across the world and included the Commonwealth, which included Canada, Australia, and of course New Zealand. And that had significant impacts. You can't really talk about colonization and Aboriginal health, or you must talk about the connection between the two because they inform one another. Consequently, in Canada, there were a number of treaties that were determined, and they're like contracts that were developed between the Crown in England and or modern treaties in Canada and the various groups as the migration moved across the country. And it's important to recognize that treaties are agreements and contracts between two parties. So it's not like Indigenous people are a party to the treaty, so it has only to do with them. The mainstream population of these nation states, Canada, Australia, and New Zealand, are parties to the treaty, so we're all part of the treaty. It's all part of a contract. We all have a role to play in the expression and implementation of contracts. In my home community, as I mentioned, the alliance with the British meant that we signed a contract, a treaty, back in the 1700s, about 110 years before Canada became a nation state. So I went up to Waitangi because I'd always wanted to go there, and I was very interested, and I missed the treaty day by a couple of days. But I thought this was an interesting picture here, is that it's a matter of perspective about how to celebrate treaties, and I think there are different perspectives depending on where you live and where what your history has been. And so I wanted to talk to you a little bit about the health history of Indigenous people in Canada. I couldn't really talk about your health history because I haven't lived here and I'm not Maori. So this is a case where was reported by a couple of colleagues of mine. One is the former Grand Chief of the Assembly of First Nations, Phil Fontaine, and other colleagues that I worked with. And it's about a Canadian genocide which was came about as a result of this National Inquiry, the Truth and Reconciliation Commission report. And what it involved was they looked at Aboriginal children who were basically in these church-funded residential schools. The federal government provided funding for training at these residential schools, and consequently the children there weren't getting enough food to eat. It was well documented. And this was in the 1940s, and it basically turned out that it turned out to be a very good experimental model to look at the efficacy, or at least try to look at the efficacy of vitamins and minerals that are being developed at the time. So they basically conducted nutritional experiments on children who were taken away from their families and forced into these residential schools. Now, Canada conducted this series of nutrition experiments on First Nations children in the residential schools. And this was disclosed recently by a geographer at the University of Guelph in Ontario. His name's Ian Mosby, who's not an Aboriginal person. The experiments were supervised by Dr. Tisdale, who was one of the co-inventors of pablum, which is a formula for infants that was quite groundbreaking and useful at the time, providing micronutrients and vitamins for children. Children were placed on special diets and denied basic dental care to see if their gums would bleed. The idea there was if these consequences, side effects of these vitamins and nutrients they were denied services. So it's a lot like some other trials where they knew that there were treatments available, but the treatments were not made available because it was part of a research study. Something like the Tuskegee trial that many of you are familiar with, the syphilis cohort that was denied treatment even though the treatments were available. None of this was done with their knowledge or their parents' knowledge or consent. Survivors of these experiments were recalled being hungry all the time. And then today, diabetes and obesity are intergenerational eating disorders among these residential school survivors. So the developmental origins of health and disease and the biomedical and clinical research that we now are engaging in, and we're actually starting to do some of that work, is starting to prove that having calorie limitations during developmental stages actually predisposes you to diabetes and other chronic conditions later in life. I'm not really trying to, badmouth Canada outside its borders. I'm just trying to say that when Indigenous people look at health and research in general and healthcare institutions, there's a history there. There's a reason why people were not served by these institutions, and those memories of those histories are still alive. So that's another thing that wouldn't occur to you unless you had a knowledge of it. I wrote a paper about this with a couple of colleagues. One of them is my wife, Charlotte there. And it was looking at a Royal Commission report that happened in the 1997 and then comparing it to this other report, which was the Truth and Reconciliation report in 2017, a 20-year period, and basically came to the same conclusions. Now, of course, some things had happened in those 20 years, but it wasn't the changes that we had hoped for. So I wanted to go into a little bit of the Canadian history just to explain a little bit about why it was that, and maybe we can draw some parallels to the circumstances here, because the context, again, is so important. So this is a picture of our first Prime Minister, and one of the board members who were sitting on the board for the Truth and Reconciliation Commission asked the question, what is it about the ways that we have organized our lives, like in Canada, and our communities and our resources in this country that has made one group so disproportionately unwell? And it's a question I think all Commonwealth countries could ask of their Indigenous populations. So, of course, any good diagnosis begins with a family history. So let's look back at Canada's family history. Let's look back to the first head of our household. So Sir John A. Macdonald made this statement in Cabinet and on the floor of the House of Commons. No Indian should be withdrawn, or Indian children should be withdrawn as much as possible from parental influence, and the only way to do that would be to put them in essential training in residential schools where they will acquire the habits and modes and thoughts of white men. So it was definitely a forced assimilation agenda. These children were taken from their parents and brought into these government-funded religious residential schools. And there's an example of when they're learning the alphabet, I guess, but it's obviously transmitting a lot more than the alphabet there with the banner looking unto Jesus. Now this individual here is our Prime Minister prior to our current Prime Minister, Stephen Harper. And he actually did make a very emotional apology to the survivors of residential schools in the House of Commons back in 2008. But my take on that was, I think he said, okay, we're sorry, end of story. Let's just move on, forget about it. Well, it's not that easy, it turns out. So now we have a new Prime Minister who's actually campaigned and talked about the narrowing the gap and issues around health determinants and other factors related to Aboriginal peoples. He said, no relationship is more important to me and to Canada than the one with Indigenous peoples. It's time for a renewed nation-to-nation relationship with Indigenous peoples based on the recognition of rights, respect, cooperation, and partnership. And those words were pulled from letters that were in the extracted from ministerial mandate letters to 30 cabinet ministers who were running each of the departments. So the question is, we have a 150-year birthday last year in Canada since Confederation in 1867. We have Sir John A. Macdonald, Stephen Harper, and Justin Trudeau. Of course, his father was also Prime Minister. And we're calling reconciliation the unfinished business of Confederation. Recently, Justin Trudeau made some very provocative statements in the House of Commons with his Justice Minister, who's a First Nations woman from BC. And they are going to look at redefining the relationship between Indigenous people and Canada as a nation state. So stay tuned. This is like, there's going to be some things happening, especially as we move forward toward another federal election. I did actually pull something. I love the internet. You can get all kinds of great pictures from there. I got this out this morning, and it's from your new New Zealand Prime Minister, who is standing alongside her husband there up at the Waitangi grounds. And at the bottom of that, she says there's much to do. In the past few days, she's spoken with iwi about health, education, housing, roads, employment, and now makes the statement that we must turn talk into action. Great. That sounds very interesting. So we've got these two prime ministers of two post-Commonwealth countries who are sort of on the same page. It might be a good opportunity to start some bilateral discussions around how Canada and New Zealand could actually function together. So I apologize if this wasn't what you expected. It has more of a political bend, but you don't get to speak to a Minister of Health every day. Here we have a leader in Canada. He's an Indigenous physician and president of the Indigenous Physicians Association in Canada. They met in Vancouver at their annual General Assembly. And he's talking about reconciliation and health. I think his words are very well thought out. When reconciliation is talked about, we often talk about sharing history. We talk about sharing recommendations and stories from the Commission, and those are all very powerful things. But when you look at what reconciliation is, it's the changing of two groups, two different groups, often on opposite sides, becoming something better, both becoming something better. It's not just about empowerment of First Nations or First Nations patients. It's about empowering you or us. To be allies and to find our place in the Canadian fabric that doesn't exclude Indigenous peoples. So it's about an inclusive partnership. It's about going down the river together, not interfering with each other, but helping each other and being friends. Decolonization is about the undoing of colonialism, where a nation established and maintains its domination over dependent territories. It requires both systemic and individual efforts. So there is some helpful documents in the global press and the global policy domain talking about the rights to self-determination, the right to actively be involved in health and developing and determining health, housing, and other economic and social programs, traditional medicines, accessing healthcare practices and programs without discrimination, to all social and health services, and achieving the highest attainable standards of health and well-being, including mental health. So this is our Minister of Indian Affairs, or it's called Indigenous Affairs now. Dr. Carolyn Bennett is a physician who started the Public Health Agency in a previous government. She is a very strong advocate for Indigenous health and women's health. And of course, Carolyn is now moving forward to redefine the relationship in partnership with Indigenous peoples around this sort of treaty-based nation state, like similar to the kinds of model that is in New Zealand, I think. I'm here to announce on behalf of Canada that we are now a full supporter of the declaration, that's the International Declaration on Indigenous Health Peoples. Without qualification, we intend nothing less than to adopt and implement the declaration in accordance with the Canadian Constitution. So she's saying they're going to change the Constitution, I think. The Truth and Reconciliation Commission specific healthcare recommendations have to do with Canada's role in acknowledging the poor health of Indigenous peoples, recognizing jurisdictional challenges, training more health professionals, increasing the cultural safety of health services, creating mandatory skills-based training for intercultural competency, these among non-Indigenous medical practitioners, conflict resolution, human rights, and anti-racism for physicians and nurses. I mean, these are explicit things that came out of about 3 years of consultation with communities. Providing resources for healing centers and recognizing Indigenous healing practices and reporting on progress, report cards with specific health indicators. Another minister who is also a physician who works in global health and primary health care and who also has an appointment at the Dallana School of Public Health at the University of Toronto is Minister Jane Philpott. And she was the federal Minister of Health, and she moved into Indigenous Health Services, part of the Indigenous program, working alongside Carolyn Bennett. But at that time, she said, we're committed to renewing our nation-to-nation relationship with Indigenous peoples, and my department's ongoing work to improve health services for First Nations is fundamental to achieving that goal. So you get the idea here. We're actually, at the federal level with Cabinet, there's a lot of movement towards creating a policy and a funding environment to fundamentally redesign the relationship. So in the place that partially funds my research chair in heart health and well-being, this is the phrase that kind of stands out, nothing about us without us, and it involves a level of reciprocal accountability between various parts of the government with respect to Indigenous health issues. I won't be going through all this slide just to show you that it wasn't that easy to move this whole agenda forward, to take over the healthcare services of an entire province. It involved trilateral arrangements with the federal government, which is responsible for Indigenous affairs, and the provincial government, which was responsible for healthcare affairs. But it was done, and it is operating, and it spends about $700 million a year on the provision of services in the province, and an additional $300 million probably comes from the province for tertiary care services. So it is about reciprocal accountability, and if you haven't heard that, it's about working together at all levels in a collaborative manner to achieve shared goals. I will be providing these slides if any graduate students or anyone else is interested. They can also look at them later. But there are some common ideas, foundational ideas here about turning the health care system into a wellness care system is sort of the short brief on that. And that's the idea, is try to hear the voices of communities around the priorities and what to do, and get some respect back to into the healthcare system for patients' rights. Not that it's not there, but sometimes it's missing in Indigenous populations. So it is a tripartite arrangement between the Ministry of Health at Health Canada, the Provincial Health Services Authority, and other regional health authorities which also participate. So there's a lot of interaction going on. And I thought it was an important model to at least be aware of. Again, cultural safety and humility is an important aspect of all this. It talks about cultural competency, something we strive for. Cultural humility is the only way we can get there. With an open heart and open mind, we can increase the space for cultural safety. By the way, this all came from New Zealand. we stole this from New Zealand. A couple of nurses came up with this notion here in New Zealand and wrote about it, and it's just taken off in Canada. This is, I thought I'd better put in a slide about good, healthy eating. I barbecued all this stuff on the top right-hand corner. That's not an indigenous chicken. That's a regular chicken you buy at a store. So. There is a lot of ideas that float around Aboriginal people about being risky and vulnerable and marginalized, and there's a lot of inequality. What I'm saying here is that words matter, and they're not like substitutes. You have to use the right words. So it starts off with social exclusion, which I tried to show a little bit, which leads to marginalization. Marginalization can lead to inequality. Equality leads to risk. Risk leads to vulnerability. And the cycle can get worse as you go through it. It can also be turned the other direction if you actually intervene and break that cycle to try to improve and lift up communities that are, need equity and they're marginals. So what we have here is something that we all know about, which is this life course perspective. And this is a utopian picture of how one goes through that journey of life along this path. At various life stages, things happen and we kind of live life, and it's a wonderful opportunity to enjoy. Sadly, it's not always the case in Aboriginal peoples. This is a paper we got published in the Canadian Medical Association Journal back in the 90s, and it basically is showing a 6-fold higher rate for diabetes for Indigenous men and women compared to mainstream Canadians. And nothing much has changed over the 20 years because we haven't addressed the underlying social conditions and the different opportunities within the life course. So I'm going to go quickly through this because I expect many of you understand this, but there's this idea to optimize a developmental trajectory through the life course. So each stage, there's stages that you can address, and then there's things that become cumulative as you go through the course of life, depending on what you do in each stage, of course. And so what really matters is this complex interaction of health determinants, in particular Aboriginal Indigenous context, over the entire life course. It becomes a cumulative. Not to say that there's always room for improvement, there's always room for getting better. No matter how ill you are, you can always intervene. So there are a bunch of factors that look at these social determinants, which we all know about. Genetic endowment in biology is emerging as a very strong area of research interest, and we actually just got a very large grant to look at what we're calling silent genomes, undiagnosed treatable illnesses among Aboriginal kids in Canada. So there is a paper written by John Frank, who's in Great Britain, but this is, in case you're interested, it gives a better explanation of this sort of framework for balancing social determinants with life course and looking at health services where we spend billions and billions of dollars, and the other factors that affect health where we don't spend nearly as much money. So the idea is let's reinvest into some of the things that determine health at critical stages of the life course to avoid some of the consequences of health services down the stream. Again, if you're going to do that, you want to focus where the bang for your buck is going to be best. My personal interest is getting in and looking at maternal child health, which is really the health of women, and looking at women's health as especially women of maternal age, and then looking at the intrauterine environment, and then tracking, especially through the early stages of life, to make sure that everything that can be done is being done to optimize the developmental opportunities for kids. So this is the last slide. I wanted to just wrap up. This person, Noel Morrison, he's passed away. He was given a bucket of paints, different colors in prison when he was in his 40s, and he invented something called the Woodland School of Art. And he's extremely well recognized. This figure on the bottom, that's actually an adult person with a head and shoulders. So that gives you the size of the scale of this piece that he actually drew or painted. And he called it androgyny. I like it because it represents the Ojibwe shaman's view of the world. It shows a thriving and bountiful world in which all the diverse elements are in perfect balance. And I think, to me, it really exemplifies the fact that there's much to be learned and gained from engaging with Indigenous communities. And at some point, we're going to get to a point where we can actually have this reciprocal relationship and improve well-being together. Thank you very much.